Good morning. My name is Peter Stanton, publisher of the Worcester Business Journal. And it's my pleasure to welcome you to our 9th annual Central Mass Healthcare Forum. This yearly gathering of industry leaders has produced entertaining, informative, and sometimes riveting conversations about the future of the healthcare sector in our region. And I expect this morning's conversation will live up to that high standard based on the impressive keynote and panel we have with us this morning. Making this annual healthcare forum happen takes a lot of effort, and we appreciate the support we've had for years from our event partner and presenting sponsor, Fallon Health. The Fallon team has not only supported the event, but been a think tank partner when it comes to choosing timely topics and recruiting speakers. I'd like to ask Richard Burke, the president and CEO of Fallon Health, to share a few thoughts. Richard.
Thank you, Peter. Good morning, everyone. Fallon Health is pleased to sponsor the 2020 Worcester Business Journal Central Mass Healthcare Forum. Thank you to the Worcester Business Journal team for bringing together a distinguished panel of experts to discuss a number of timely topics and issues. 2020 has tested the resolve and resilience of organizations and their people like no other time that I can remember. At Fallon Health, we have responded to the current crisis by supporting our members, our employees, and the larger community in which we live. From the outset of the pandemic, we have urged our members to embrace telehealth, and they have. We have reached out proactively to our members, particularly our most high-risk members, through a program we call Operation Stay Connected, to check in and to ask how we can help them through this crisis. At Fallon, we have also increased our commitment to our community, the Worcester community in particular, by being an early supporter of the Worcester Together Fund. This year, we have increased our community giving, especially to support much needed food insecurity efforts. In total, Fallon Health has donated $500,000 to COVID relief efforts across our community. And finally, an important part of Fallon's commitment to our community is to support forums such as this. And we are very pleased once again to partner with the Worcester Business Journal and the good work they do to bring information to our community. And with that, I'll turn it back over to Peter.
Thank you, Richard, for your support and for all Fallon has done to step in as a leader in this at this time of the crisis. So it's my pleasure now to introduce our keynote speaker, Dr. Donald Berwick. He is President Emeritus and Senior Fellow at the Institute for Healthcare Improvement, an organization he co-founded and led as President and CEO for 19 years. He's one of the nation's leading authorities on healthcare quality and improvement, served in the Clinton administration's Advisory Commission on Consumer Protection and Quality in the healthcare industry, and he was appointed by President Obama in 2010 as administrator of the Centers for Medicare and Medicaid Services. Dr. Berwick has served as a clinical professor of pediatrics and healthcare policy at the Harvard Medical School, professor of health policy and management at the Harvard School of Public Health, and as a member of the staffs of Boston's Children's Hospital Medical Center, Mass General, and at Brigham and Women's. A full read of Dr. Berwick's list of accomplishments and honors would cut short his talk, but suffice it to say, he is a highly decorated world-class leader, thinker, and contributor in his field, and we're pleased to have him with us this morning to share his thoughts on how the pandemic is accelerating change in healthcare. It's also worth noting that Dr. Berwick is not the first member of his household to keynote a Worcester Business Journal event. That honor goes to his very accomplished wife, Anne, who delivered the keynote at the Massachusetts Solar Summit in 2012 in a role as the chair of the Mass Department of Public Utilities. So you can tell that dinner table conversations at the Berwick household have to be very interesting ones. It's all yours, Dr. Berwick. Thanks for joining us.
Well, thank you so much, Peter and Richard and all of you for the chance to spend some time with you. Great to get to join you. I'm very excited about the panel upcoming. Many of my friends are on it, and I'm anxious to hear how things are going for them in your part of the state. My remarks are going to be for stage setting. In the next 20 minutes or so, I'm going to tell you a little bit of my thinking about what's going on with the pandemic, what we're learning from it, and then widen the zoom lens and look at some of the broader issues that the pandemic is not exactly bringing to us, but that's underlining, that it's underlining for us. I want to make sure that you also can see the screen. Is that working okay? So
Yes.
let's start with the COVID pandemic, this tragedy, this horrible situation that's facing us in the world today. I was asked to write a paper for the Journal of the American Medical Association some months ago about the new normal, what's different in the pandemic era. What I chose to write about was choices for the new normal. These are 6 categories of change that the pandemic has thrust on us in the healthcare world that can be thought of as opportunities, tragic ones at the outset, but maybe something we can trampoline off or leverage off. And let me just quickly run down there, and then we're going to end and spend most of our time on the last of them. The first is speed. I've never seen the pace of change in healthcare that the pandemic has brought us. Richard spoke about switching over to virtual care. We're seeing journals turn around papers in hours that used to take months. The National Academy of Medicine is issuing guidance in cycle times of weeks. It usually takes 1.5 years to get a guidance document from the National Academies. We're converting our delivery systems with enormous pace, and we're now going to see it also with the vaccine era. As vaccines arrive, we'll be challenged to move much more quickly in deploying at enormous scale a new treatment, more than we've ever done. This is actually a choice. We can decide to keep this kind of tempo of change and agility, I guess I'd call it, as opposed to a rather slow-moving change process that's characterized healthcare in the past. That, of course, brings risks with it because the changes have to be proper and safe. The second choice I focus on is standardization. As my colleagues who run healthcare systems will testify, there's often a lot of controversy between trying to standardize healthcare to the best known practices so we do the right thing for every patient every time, and a kind of equally valid commitment of physicians, especially to their own autonomy, to the chance to do it my way instead of a standard way. COVID has changed that. Standardization is now much, much more attractive to the clinical forces. They're looking all over the world for evidence on what's the best way to prone a patient or use remdesivir or whatever. And I think it's going to give us a choice. We can build on this to tighten up our commitment to science or not. The third is the virtual care that Richard referred to. The shift has been phenomenal. A community health center leader in Boston told me that they had switched from 5% virtual care to 95% in 1 week. And this whole new way to be together, including today's meeting, which would have required travel and now doesn't, is offering us some pretty important choices in the future. We're going to need to adapt to that in our training systems, our payment systems, our infrastructures. But this may be a real improvement. And it forces us also to reconsider what I would call overuse of care, because a lot of the visits that we have become time-honored in healthcare, they're turning out not to be necessary. There are some visits that certainly are and will pay a price for patients that aren't coming into care who should. But there's a lot of patients who are skipping encounters that turn out to have been unnecessary, actually brought to you by the fee-for-service payment system. And that's going to raise some really interesting questions about the care patterns we want. Protecting the workforce is key. We dropped the ball on that. I look forward to hearing from some of my colleagues on the panel about how they've recovered, but we didn't have the equipment, we didn't have the commitment, and we misinterpreted the workforce. The healthcare workforce is much bigger than we ever thought or ever considered. The people that drive the vans and serve the food and clean the rooms, the grocery clerks who are giving us our food so we can go to work, those are all part of a larger concept of what the essential workforce is. Preparedness itself could be a topic for an entire meeting, and maybe should be. The United States was rated as very prepared for a pandemic in WHO and United Nations rating schemes. It wasn't. We are on our heels. We still don't have a national testing plan. We still don't have a sense of order or unity in the country for dealing with pandemics and threats like this. And this is not the last 21st century threat we're going to face. There are others, and we'll have to learn from this and rebuild a public health and preparedness infrastructure that works, that involves public-private partnerships at a level we actually haven't considered before. And finally, inequality, disparity. That's what I'm going to focus the remainder of my remarks mainly on, but you all know the data. African-American patients with COVID dying at 3 or 4 times the rate of whites, Latinos just a bit less than that, but still a multiple. The pandemic itself is selectively affecting people of color and people at lower income levels in all sorts of ways, including economically. And I think it's a choice. I think our country has really got on the table now a chance to reconsider a several century heritage of inequality. It's always been there. We've always fretted about it. We actually may be called to our mission to do something about it. I'll dive deeper into some of these topics for you, mainly around inequity. We mentioned the workforce. Inequity affects the workforce in healthcare deeply. Back in May, appeared this article: more than 800,000 healthcare workers and almost 1.1 million of their children in this country live in poverty. They're below the federal poverty line, even though we employ them in healthcare. The median income for some categories of job in healthcare, like home healthcare aides, is at or below the poverty level in the US for a family of 4. We employ about 18.5 million people in the American healthcare industry. 10% of them are paid so little that they have to get healthcare through Medicaid. And here's a figure we need to reconsider: 1.4 million workers in healthcare, almost 10% of the healthcare workforce, has no health insurance. So that the equity issue is not out there, it's right in here. And I'm going to take us to school a little bit on this issue of inequality in health and well-being with the help of this guy, Michael Marmot. Sir Michael Marmot is one of the most distinguished epidemiologists in the world. He's in England, but he studied health disparities and healthcare disparities around the world. In 2015, he wrote this book when he was president of the World Medical Association. Michael's book, The Health Gap, I recommend it strongly. I think I would believe it should be required reading for every healthcare leader, probably every person concerned about healthcare in the world and in our country, because we don't come out looking so good. And I'm going to go into that a little more, but our country stands in health status, although we're spending nearly twice as much as the next most costly country per capita. We stand near the bottom in health status metrics for the OECD nations, in the well-being of children, in life expectancy, in overall measures of vitality. We're not getting value for the immense amount we're pouring into healthcare. And that's because healthcare doesn't create health. Healthcare is a repair shop. And Michael lays out very helpfully the scientific literature over really a century that has documented what are called the social determinants of health. This has to do with the real causes. What is it that creates disease and illness and injuries and disabilities in our communities? This is the list. There are 5 topics that Michael dives into very, very deeply. Page after page of recitation of the research on these 5 areas of social determinants. The first, in some ways the most powerful, is early childhood. The evidence is incontrovertible. The experience of children in the early years of their lives, toxic stresses and adverse childhood experiences, exposures they have to stresses in their lives, these very strongly predict longevity and health status in adulthood as well as in childhood. Kids with 4 or more adverse childhood experiences, for example, have over double the rate of lung cancer and cardiovascular disease as people with lower stresses in childhood. They have 10 times the rate of substance misuse and mental health issues. Early childhood is a massive determinant of health. The second is the education system, the equity, the depth, the support, the solidarity of the education system in a country. It strongly predicts well-being in the society as a whole. The correlation coefficients are very high. Countries that invest strongly in superb education for everybody live longer. The third are conditions in the work and workplace. Among these is minimum wage. The United States minimum wage is set at a level that in any other country we regarded as rather severe poverty. Our minimum wage was set in the 1950s by the Department of Agriculture's metric of food security. Our minimum wage at that time was set as simply 3 times the minimum amount of money a family has to spend on food to stay alive. That was the definition of minimum wage. It's been modified somewhat since then, but it still remains far below what other countries regard as an essential income for a healthy life. That's not the only workplace issue. There are matters of meaning in work, the way workplaces work as social systems, and also safety at work. The fourth category that Marmot goes over is community infrastructures to support elders. Countries and regions that invest in connection of elders, maintaining access to workplaces, giving them social connection, avoiding loneliness. These countries live longer. And the fifth is a potpourri of community resilience factors, very well documented. It's quite a long list. Transportation, food security, approaches to violence and criminal justice in a society, availability of green space, and a list of other things that characterize the resilience, the capacities of communities correlate extremely strongly with health and well-being in societies. These correlations are true among nations, within nations, among cities, and they are massive. I'll show you that in a minute. The sixth in Michael's list is not a determinant of health so much as what he calls it a cause of the causes. Societies that exhibit a sense of what he calls fairness, it's sort of like solidarity or mutuality or a sense of interdependency, they live much longer than societies like ours that are much more fragmented and engage in othering, in which the sense of solidarity is lost. Michael goes so far as to say this: inequities in power, money, and resources, which for him is an index of fairness, give rise to inequities in the conditions of daily life, the social determinants, the other 5, which in turn lead to inequities in health. That is a statement with political implications. It's not a political statement. It's Michael Marmot's summary of the scientific literature. The depth of these problems in our country is massive. I want to show you this. And by the way, I would recommend maybe for the WBJ, you might take this seriously and take a look at your region of the state. This is a report just came out in October 2020 on the Child Opportunity Index. It's an index that's existed for quite a while, authored by a number of universities. It rates small regions in the United States, sort of zip code level, I think, neighborhoods in what they call child opportunity. And it's done this for years. The index is made of a whole bunch of variables. These are the variables, the arguments in the Child Opportunity Index, which it's basically a rating of the conditions in which kids find themselves in a relatively small geographic area. There's a similar index being used, by the way, in the province of British Columbia. Should there be any interest in the Worcester area in this, I'd be happy to put you in touch with a BC group that for over, I think, 30 years have followed every single child in British Columbia with respect to the conditions of life, the stresses those children are under. It's a massive database, one that a lot of lessons can be drawn from. So when you use this index, you end up with the ability to rate neighborhoods. This is hypothetical neighborhood A, neighborhood B. These are 5 of the components of the index: poverty rate, early childhood support, green space, food security, housing vacancy. And here's a neighborhood which is highly stressed, very low opportunity with respect to these indicators. Here's a neighborhood which has much more opportunity with respect to those indicators. The correlation between child opportunity and race is profound in this country. This is American data in which every single neighborhood is being rated from very low opportunity to very high opportunity. This is the distribution of neighborhoods in our country for white and Asian Pacific Islander kids. This is the same distribution, very low to very high for African American and Hispanic kids. This is a highly racialized, a highly segregated distribution of the conditions of life for children according to race. This is structural racism that we're talking about now, as we'll see in a moment. Here's how it appears in the Baltimore, Columbia, Maryland, Towson, Maryland area near our nation's capital. This is the map of that area in which Neighborhoods are being grouped into 5 categories: very low to very high opportunity, dark is high opportunity, light is low opportunity. And here's the distribution of residents of white children in that Baltimore metropolitan area. Every single one of these tiny dots represents 20 kids, 0 to 17 years of age, mostly living in the darker areas on the map, that is areas of much higher opportunity. Now you layer in Black children and where they're living in that area, and you see structural segregation, redlining, racism today. This isn't 100 years ago. This is the maldistribution of opportunities for growth, development, long life, and health according to race in our country. It's structural. It's a social determinant of health. And the only way to reverse this is investment in those components that create opportunity in geographic areas, which is not segregated. The consequences, this is the mortality, infant mortality. This is the year 2015, to be the same today, where the Black African-American infant mortality rate is much more than double the white infant mortality rate. American Indians, a very deprived, disadvantaged segment of our society, also similarly affected. It's playing out, as you all know, in the COVID epidemic. The pandemic is selectively hitting racial groups in our country that are part of that pattern of disadvantage and structural racism. Here's the Black to white ratio of COVID-19 mortality, with 1 being the white rate. So here, unadjusted, is Black men and women dying of COVID at 4.2 and 4.3 times the rate of whites. If you adjust for those social determinants like urbanicity, age, and so on, you get some change in risk, but it doesn't go to 0. What this means is that the effect of race itself, independent of socioeconomic status, still persists in our country, as played out in COVID, but in other risks, beyond the measured social conditions. This is a direct effect of racism on well-being. My colleague at Harvard School of Public Health, Dr. David Williams, has written eloquently, deeply about this relationship between race and well-being, and may I recommend at a future one of your meetings. If you've not invited Dr. Williams, Professor Williams, he would be an extremely important voice for you to hear about what is going on here dynamically, because I know you're a community that would like to change this. We take a look at this, the magnitude of this, a lot of ways in the scientific world. One of them is called a subway map. This is a subway map of London, in which the subway lines are represented here, and the circles are subway stops. And each circle on the map it has a number in it, which is the median life expectancy, the average life expectancy for people who live in that area. Here, for example, is a very wealthy area of London. There's Oxford Circus, Tottenham Court Road, Piccadilly Circus, where the numbers are in the 90s. That's the life expectancy. It's extremely high. Over here in East London, about 5 miles away, here's the Star Lane subway stop, or a London Tube stop, where the life expectancy is 75 years. This is a typical subway map. Across the geography of a single city, life expectancy differences here, 21-year difference in life expectancy. That means when you board the London Tube on your way from Oxford Circus to Star Lane, you're losing about 2.5 years per mile traveled. For every minute on the subway ride, life expectancy drops 8.4 months. That's not quite true. This would imply it's like a ramp. It's not a ramp, it's a cliff. The areas of health disadvantage in London, as in all cities, are isolated areas. It's like you fall off a cliff when you hit the social conditions in those areas. This is a story in New York City. Here's Midtown Manhattan, average income about $180,000 a year, largely white, almost all white, and high rent. This is the South Bronx, almost all areas of color. and much poorer in income. Income in this area is less than a third of what it is in Midtown Manhattan. As you travel the D train from Midtown Manhattan to the South Bronx, you're losing about 2.5 years per mile, 6 months per minute, and experiencing a life expectancy of 10 years difference. I want to show you how big that is. 6 months for every minute on the subway, 3 years every mile traveled across a city. The way I'm showing you this is with respect to a medical breakthrough, statins. As my colleague physicians know, statins are regarded as a pretty big success in medicine. Most of you on the listen to this Zoom are probably on statins. A third of Americans are. This is a review in the British Medical Journal asking how good are they? And this review of all papers at the time on statins showed that in primary prevention trials, the best, the most favorable report was that statins add about 1 day of life for 1 year of treatment. If you're on statins for 20 years, you add about 20 days of life to your lifespan in primary prevention. 20 days of lifespan, the effect of statins in 20 years of treatment equals 7 seconds on the D train in that ride from Midtown Manhattan to the South Bronx. It equals 43 feet on the bus in the city of Glasgow. What it is in Worcester, I don't know, but I strongly suspect Eric would know that the disparities across your city in Worcester are, if not identical, they're of similar magnitude. Healthcare is a repair shop. It doesn't create health. What creates health is the investments we make in our society, and the effects are massive. So are the defects. This is the growth of life expectancy between men born in 1920 and men born in 1950. It's a 30-year period. So these men born in 1950 are today 70 years old. The growth in life expectancy for wealthier portions of our population are substantial in the 30 years between here. For the poorest 10%, almost not at all. And for women in our country, life expectancy at age 50 has fallen. For the poorest 10, 20, and even 30% of women, wealth and life expectancy are very, very strongly associated. And we've not broken that connection. That connection has increased in our country, along with disparities and unfairness, and of course, racism. Underneath, among the cause of the causes is structural racism. It remains deep in our country. The murder of George Floyd surely brought this to the national consciousness yet again, but it's been there. It's been there for well, since slavery started 400 years ago. And that's the final point I want to make. Everything I've just shown you about what creates health and well-being, the characteristics of our society, the way we treat kids, the way our workplaces work, how we manage elders, infrastructures in our communities, we've known. There's nothing new in Michael Marmot's book. The research showing this massive effect of the nature of communities on well-being is decades old, and we have not done almost anything about it. We continue to pour money into a healthcare system that takes 18% of our economy in the repair shop. It's as if we keep running a garage that fixed dented fenders and we just don't fix the roads, even though the evidence is absolutely clear. And I don't know why. I think it's a good topic for our panel. Why have we not created health in America? Part of it is money. There's a lot of money to be made. A lot of it is in the economic structures. But I've taken the leap of referring to our moral compass as key. These are the 7 areas that I think we would invest in as a country if we really wanted to shift to an investment in well-being instead of a repair shop only. We would join the international regimes on human rights. The United States has not signed basic conventions on human rights of the United Nations community. We have not signed the Convention on the Rights of Children, the Convention on Rights of Women, the Convention on Rights of Migrants. We have stayed aside from the human rights commitment. And the second on the list is the commitment to universality. We're the only developed nation on earth that does not make healthcare a human right. Massachusetts is better than that. We have taken enormous steps way back to the laws of the beginning of this century to make healthcare available to everyone. We're not there yet in this country, and it's time. We would have to get engaged with climate change. You could have a whole session on climate change. It's going to be as big a threat to health and well-being in our nation and the world as the pandemic, and then some. And yet, as you know, we withdrawn from the Paris Accords, and we're not playing our part in stopping climate change. We would reform our criminal justice system. Of everything on this list, it probably is the thing that offends me the most to know we have 2.3 million people in our prisons in this country, 10 million cycling through our jails every year, a 7-to-1 ratio of African-American to white, 5-to-1 Latino to white. We have a criminal justice system that in its performance is an embarrassment in the global scene. We incarcerate people much, much more than any other country on earth, including Russia. It's the new Jim Crow, to quote Michelle Alexander's book. It's time for radical reform of our criminal justice system, and I'd love the healthcare industry to leap into that task. We need to achieve compassionate immigration reform. Our Congress has run away from that problem for decades, and we are doing things at our southern border that should just simply embarrass us. And hunger and homelessness in our nation. Tonight, there are at least 17 million hungry kids in the country. We're up near, I think, 40 million food insecure people in the pandemic. This is a country that commit to complete elimination of hunger, complete elimination of homelessness. You could do that in Worcester, and yet we continue to run the repair shop. And finally is the security of our democratic institutions. Everything on this page and everything that Marmot talks about requires a functioning government, a government that works with compassion and order and dignity and science. And it's crucial to restore that integrity of government at every level in our country. Of course, I think that depends on the integrity of the vote. And we have a lot of conversation to have in this country now about the idea of one person, one vote. We're nowhere close to that. In the Electoral College, in a rural state, a vote counts 70 times as much for president, 70 times more than a vote in an urban area. So we've got some work to do here. I think it's not just important. I think it's within our reach. I love the idea that you're together in your community thinking about these issues, because it's an all of community effort that's going to take everyone involved. I think healthcare should be in the lead. I think the healthcare organization should take on the moral determinants of health and get us back to proper investment in the well-being of our posterity. Thanks, Peter. I appreciate the chance to have joined you here, and I'll stick around now for the panel.
Thank you, Dr. Burke. That was, I think, a great talk and really a challenge, an introduction to our panel conversation. A lot of topics I think we can follow up on and discuss. And certainly, I know a number of leaders on this call have a lot of knowledge about the healthcare scene in Worcester, and certainly some goals to, as you mentioned, to improve that. So I'm gonna introduce our panel. Our moderator, actually, I won't introduce our panel. I'm gonna introduce Brad Kane, who has just appeared, who's the Business Journal's editor.
All right, well, just jumping right into our panel here, let me introduce our panelists. We have Lou Brady, President and CEO of the Family Health Center of Worcester. We have Dr. Eric Dixon, President and CEO of UMass Memorial Healthcare. We have Carolyn Jackson, CEO of St. Vincent Hospital in Worcester. Dr. Carolyn Langer, Senior Vice President and Chief Medical Officer for Fallon Health. And again, Dr. Berwick has been kind enough to hang on to join the panel discussion as well. So looking forward to hearing everyone. So I know this hour is going to fly by rather quickly, so I'm just going to jump right in. And I know we have a lot of big topics, and certainly Dr. Berwick talked about many of them. But one I think probably more immediate at the forefront of most people's minds right now is vaccines, particularly the COVID-19 vaccine, and when it seems likely it's going to be in central Massachusetts and how that's going to roll out. So Carolyn Jackson over at St. Vincent Hospital, I know we talked about this before, but just from maybe a process standpoint, and what can you tell our audience about where we are at with vaccines?
Well, good morning, Brad. Happy to be here this morning. And actually, Eric and I were on a call earlier today with the other CEOs of the Commonwealth of Massachusetts, conducted by the Massachusetts Hospital Association. We got a lot of great vaccine information, so your question is timely. We anticipate the Pfizer vaccine being in central Massachusetts early next week, with the ability to start vaccinating our healthcare workers by midweek next week, if not before. We had heard we might get the vaccine as early as this Friday, so I think still perhaps a little bit in flux, but we will be getting as they're calling them, the pizza boxes, 970 doses per box. And it sounds like there will be, by the end of the year, I believe about 300,000 doses for healthcare workers in Massachusetts. So we are working on processes, as I'm sure every hospital is. We have our room where we're going to be doing it. We have lines on the floor to promote social distancing, and the spaces set up for people to give the vaccine, to register. There's a lot of details, but the good news is vaccines are something we do all the time. So it's just a matter of adapting processes to this particular vaccine and its needs. So we are ready and prepared and excited to receive the vaccine. And we have been educating our staff about the vaccine and are finalizing our operations plan for administering.
And then, Dr. Dixon, I know that you had a lot of insight on this as well. And as, I guess, the leader of the largest health system and employer here, maybe if you could just follow up on what Carolyn said there as well.
They're very excited about the vaccine, and we think around the 17th is when we'll start to deliver our first doses. And it's the amazing part of this vaccine, it's a totally novel platform, an mRNA-based vaccine that we've not used for any other vaccination. And that's part of why we were able to get it so quickly. And I think it's going to change how we manage pandemics and how we do vaccinations in the future forever, because it's so much easier to just produce a piece of mRNA from a virus and put it into a vehicle that can be used over and over again. But so with this time of great knowledge, or age of knowledge, and this amazing vaccine that is going to become available, we also have, in Dickens' words, an age of foolishness. We still see people running around this city spreading this virus, not wearing a mask, socially getting together, and they shouldn't. And, if we could just all focus intensely on doing the right thing every day in terms of our infectious control protocols, and everybody knows what they are at this point, we could alleviate a lot of suffering, which will disproportionately be in people of color and people living in poverty, as every natural disaster impacts those living in poverty greater than those of wealth. And so as excited as I am about the vaccine coming out, it's just really tough on the healthcare workers to walk around the city or drive around the city and see people not following the rules.
So I thank you. I wanted to first thank you for inviting me to the table. There's, in my estimation, two things that lead to human progress, and that's technology and teamwork. And the technology is exciting, the opportunity to work with this new modern vaccine technology. It also requires a level of teamwork. So for our health center, we don't have the refrigeration units to help manage the level of handling needed for this vaccine. So it will require us working, shoulder to shoulder with Dr. Dixon and with others in the community to provide this to our communities. In terms of the vaccine, we at the community health centers are going to be pushing for our employees to get the vaccine, and I will be getting the vaccine, and I will be making a very public show of getting the vaccine, because in addition to access to this, we also have to deal with the issues of trust. And there is a great deal of trust deficit, especially between Black and Brown communities and the medical community. So it's important not only for us to provide access to the vaccine, but to provide leadership and to communicate the vitality of this and the safety of this. So yes, we think it's important.
Even before the pandemic, healthcare delivery models are changing, with particular pressure towards lowering costs. With everything coronavirus has shown, how do you envision delivery models will change post-pandemic? And Carolyn Langer, if you want to jump on this one first.
Sure. Thank you, Brad, and it's a pleasure to join the panelists this morning. Boy, I could talk for a whole hour just on that one question alone, but I won't. I would like to make three observations. One is around the area of accessibility, and Richard Burke and Dr. Berwick already talked about telehealth. I think that telehealth is here to stay, including telephonic. And I would just note that in particular, I was extremely gratified and pleasantly surprised to see the broad uptake of telehealth, particularly among our Medicaid population. The rate of utilization within our Medicaid population was actually twice that of the commercial population. And we just need to make sure post-pandemic that we continue to make these technologies accessible. The second area is around meeting our members where they are. So providing care in the community, keeping patients safe in the community. We run a PACE program for all-inclusive care for the elderly, as well as a Navicare product. And both of these products really focus on keeping the most vulnerable, frail elders who are nursing home certifiable safe in their homes, in the communities, as a viable alternative to nursing home placement. In addition to that, we also, prior to the pandemic, had embedded navigators. In fact, many of our navigators were embedded in some of the UMass high-volume geriatric practices, as well as navigators embedded in high-volume hospitals, such as St. Vincent Hospital in UMass. We had nurses and navigators and pharmacists visiting our members in the home, and we are currently exploring ways to expand on that, providing more community care in the homes, such as hospital at-home programs. And then the third area that I'll focus on centers around social determinants of health and health disparities. So Richard already mentioned our program called Operation Stay Connected, to connect with our most vulnerable populations and identify risk factors. In addition to that, we conduct extensive care needs screening of our most vulnerable populations, such as our seniors and our Medicaid populations, and really seek to address those barriers to care and connect these members with social services and with our community partners. In addition to that, we have really expanded our focus on doing transitions of care, again, to identify risk factors in order to help our members stay safe and receive care in the community. So those are just some examples, and I'm happy to expand on that during the Q&A. Oh, you're on mute, Brad.
All sorts of phone audio problems today. Eric, do you want to pick up the same question? How are care models changing from your perspective?
I think certainly the leap to virtual medicine is progress because it provides greater access for services. I think especially in the behavioral health space, this is going to be absolutely critical. If you're suffering from depression, the thought of having to get out of bed, get dressed, get on a bus, go to an appointment, that's a Herculean effort that is often required. And if you look at those patients, we have as much of a 40% no-show rate, and not because they don't want the help, because it's so hard for them to get to an in-person visit. And now with virtual medicine and being able to do a video visit instead of that in-person visit, many more of our patients suffering from depression and things like that have been able to get the care that they need. So I think the genie's out of the bottle in terms of virtual medicine. I think the patients want to continue it. I think the providers want to continue it. And I think the payment systems seem to support continuing. And that's just going to lead to better access, as Carolyn was talking about, for patients.
And quickly, while we will touch on telehealth a little bit today, we actually have a separate WBJ webinar on telehealth specifically. So we'll probably only glancingly touch on the very important topic before we delve deep into it, I believe, on December 17th. But just as we still talk about changing delivery models, and Dr. Berwick, I think you had talked about the way things are being reshaped now. I think maybe a little bit on the ground, or maybe the next few years or coming out of the pandemic, how do you see the thinking changing around care models and then maybe it actually being implemented?
I'm pretty excited. I think telehealth is really, it's only one form of a broader idea, which is to move care closer to home. We're learning in the pandemic something we really had pretty good evidence for in advance, which is how much people can do for themselves, how much care can be home-based. We're seeing some interesting models develop. I don't know if Eric or others have experimented with a hospital at home. This is a very bold and interesting idea, which is people who are quite sick, who would normally be in the hospital, can be taken care of very, very well at home, which also maximizes the use of community supports and family supports for people that are benefit from that kind of social support. It involves new payment, new job roles, but a lot of people who are in institutions for many reasons turn out don't have to be there. Another form of this is self-care, which is we may have sold the public short. People can do a lot for their own health and well-being. People with chronic illness can learn a ton about how to manage conditions, and we convert sort of from a caregiving workforce to a teacher workforce, helping people develop capacities at home. I guess the last piece I'll say has to do with the reintegration of public health and delivery. They've developed more or less as separate worlds, but it's not true. Even in our vaccine conversation just now, the essential partnership between an endeavor to keep a population healthy and the care delivery system, especially primary care, is it's all the more evident. I think we're seeing pretty interesting redesigns. One other quick thing is primary care redesign. Primary care it's all about primary care from the health system's point of view, and having primary care that really works matters a ton. That involves an expanded view of that workforce also. And so I think we're going to see some pretty creative things happen. We'll have to change the payment system to keep up, or otherwise we'll force people back into the old ways, the old and somewhat less effective ways of doing things.
Okay. Now, moving on to questions about public policy. It's obviously been evolving for decades, and over the last few years have brought a lot of change, particularly with change in presidential administrations. With a new president coming into office, plus everything that has been going on in Massachusetts and the region, how does public policy need to change around healthcare in America and central Massachusetts? And Eric, I'll direct this one to you first.
Yeah, I'm just going to say it's very dangerous to get Don Berwick and Eric Dixon talking on the same panel about healthcare finance reform and the direction we think the nation should go in. But I think first we have to say, what is the problem that we're trying to solve? And the first is that healthcare, the repair shop, costs too much, and it's using up a huge amount of resources that need to be put into things like food security, housing security, K through 12 education. And so we have to get the cost of healthcare down. It's inequitable, not only because of the social determinants of health, but once you get to the repair shop, and where the repair shop is depends on what the poverty level is in that region. Mass General Brigham, wonderful healthcare system, some amazing doctors, is building in Westboro. We would invite them to the city campus. I'll put them right next to the Family Health Center with Lou, and because he could use some access to those specialists. But nobody's interested in getting into these neighborhoods with a high Medicaid cost. So that difference between the payment for commercial insurance and Medicaid is driving some of the inequity that exists. And we're burning out, we're burning out providers at an unprecedented rate. And it's because of the administrative burden. That's the number one cause of burnout in providers. Pre-authorizations, excessive documentation, hoop after hoop that you have to jump through to get the patients what they need. We've had children in this state die of seizures because they couldn't get their prescription filled because the pre-authorization didn't go through. Right? That's a bad healthcare system. And so at a national level, what's the solution? Single payer system, right? And here at UMass Memorial, our cost for healthcare insurance for our employees is $155 million. That's more than the cost of the pharmaceuticals we use to treat our patients to help them get better. So the medical insurance costs more than the drugs we use to take care of our patients. And we have over 100 different contracts with different payers. We have almost different arrangements with 50 different Medicaid systems around the country. If we could go to a single payer system with administrative simplification, you brought the Medicaid rates up to Medicare and you brought the commercial down to Medicare, and then our employees then had health insurance, we'd be about neutral. So it can work, but it has to be an administrative simplified system in order to achieve the cost reductions and reduce the burnout of providers. It's hard to do something just in central Massachusetts administratively, but in Massachusetts, we could get closer to that system by doing what's called a provider assessment. So for the high cost, highly paid, low Medicaid healthcare systems, they would be taxed, all of us would be taxed for our commercial market share. And that money would then go to the Medicaid system, get a federal match, and then you would bring the Medicaid rates up with those dollars. That's going to close the gap that exists between paying for those that carry a great insurance card, Fallon, for example, versus a Medicaid card. And then we have to get everyone covered. This is ridiculous that a nation with this kind of wealth cannot give everyone just a basic health insurance. And I think by bringing up the tax on us, the Medicare tax, because I no longer have the cost of paying for health insurance, you could bring it up by $155 million to us as an organization, because that's the drop in cost. If every one of my employees had Medicare, we could get everyone covered. So I hear that there's no way it would cost too much. And then I look at our own numbers and I say, you could do that to us tomorrow and we'd be even. And I think for a lot of companies that would drop their cost of paying for an employee's insurance, they could pay a higher tax and they could be even, and we could get everyone covered. And you can't do it all at once. It's too hard in this country. You have to bring it down year by year. So now Medicare starts at 60. Now, then, 4 years later, Medicare starts at 55. And by the time you get to the 40-year-olds and below, there's so low cost individuals that the system is done. So there is a pathway to getting everyone covered. It's not going to really cost all that much more or any more at all for most of us as employers. And Medicare is great insurance. And I think it's Medicare Advantage for all, because then you can design some really neat regional products where healthcare systems, Carolyn and I, can come together with Reliant and some of the other partners and work together to manage the overall cost and quality of care for people, and invest in some of the things Don was talking to, which ultimately will be the right thing for us to do from a financial perspective as well. So that's my call, Medicare Advantage for all. There's a pathway to do it, and I'm excited about this administration's current thinking on how we might get there.
So big concept, big idea. I'll throw it out to the rest of the panel, whoever wants to speak first. Lou, Carolyn, Dr. Berwick, feel free to jump in.
Yeah, I'd love to jump in. I love the idea, Eric, and I love the fact that you're at the front of the line speaking to this. So thank you for that. And it had me recalling that line from the Fram commercials from the 70s and 80s. You can pay me now or you can pay me later. It's a matter of where do we want to invest our resources for the highest ROI. I think the other thing that you mentioned briefly is really the upstream focus, and Dr. Berwick mentioned this as well. I recall the old joke I heard of a doctor coming upon another doctor at the side of a riverbank, pulling bodies out and resuscitating them and getting back in his car. And the doctor who was doing the resuscitating asked, "Where are you going?" And he says, "I'm going upstream to find out who's throwing these bodies into the water." That's really the next piece that we need to have addressed in public policy, a recognition that healthcare is more than the assembly of repair shops that we have on this call. It's also the food banks and the medical legal clinics and the community action agencies and all the places that address the social determinants of health that Dr. Berwick mentioned earlier.
So I just want to make a quick comment. I respect Eric's comments, but I also don't think that would significantly impact or sufficiently address the issues. Dr. Berwick mentioned earlier the new normal and the speed of learning and standardization. We still see a lot of variability in terms of medical care and delays in dissemination of best practices. I do think also, to Dr. Berwick's earlier point, that we need to start addressing populations, and as you're aware, Fallon is very involved in public sector programs. Our Medicaid ACO initiative has really been a success, really providing the incentive for practices to invest in the infrastructure for those types of services that previously were not reimbursed on a fee-for-service system. So being able to support care coordinators and peer navigators and other types of infrastructure to really, as Lou was saying, address some of these issues further upstream. So doing high-risk stratification and identifying members who have issues around social determinants or other barriers to healthcare, and really addressing these issues proactively.
And I do think a key component is covering everyone. I also, like Carolyn, don't necessarily agree that a single payer system is the right way to go, but covering everyone, I think, is of critical importance. And one of the things that we've seen, unfortunately, during this pandemic is people who have put off care, people who have put off preventive care, people who have needed to go to the emergency department but are afraid to go, people who have put off that screening colonoscopy or that screening mammogram. And we've seen some very devastating outcomes as a result. So it has been, I realize that this is something that in some demographics, they don't do that on a routine basis, but we've seen it play out on a more broad scale. So to me, that is the one key, is making sure that everyone is covered and has access to that preventive care, but then also that people trust the system and aren't fearful to receive care when they need it.
I would, I think we're into a very important and ultimately constructive debate about payment systems. The one thing I think I would argue we might all agree on is fee-for-service payment, just paying for every single deed you do. It just doesn't work very well. It encourages volume, and it doesn't allow us to move resources where they really matter. The reason I favor a consolidated payment system, hopefully even a government insurance program as a uniform program, is we could then move payment to a model in which we turn over to Fallon or turn over to Eric a pot of money, say, here's your population, here's resources, figure out where they should go. And I personally believe if we had a payment system which put flexibility in the hands of the people responsible for populations, they'd be very creative with that, right? And would be released from some of the traps and the handcuffs that we put on people when we say you can buy that, but not that, even if the second is what's needed.
I love that Dr. Berwick used the term consolidated system versus single payer. I think there's a certain politic that creates a polarization. So it's going to be important for leaders to figure out how to move the conversation forward around the ultimate underlying goals of reducing administrative burden, covering everyone, and having the resources go to where they have maximal impact.
It's a big topic here, healthy discussion. I know everyone's gone at least once, but I don't want to discourage the debate by sticking to arbitrary rules. Does anyone want to add anything else before we move on to a slightly different topic? Going once, going twice. Okay, Lou, I think I'd want to direct the next one to you because we talked a little bit about this in our prep call. Obviously, Dr. Berwick talked a lot about social determinants of health, and particularly about disparities among economic status and ethnic and racial groups. And I think one of the more striking things that he said was, if you eliminated all other factors, like race was still a major factor, race and racism. And that's just a topic that's a problem that can't be solved or hasn't been solved in multi-generations now, but it still needs to be addressed. So again, Lou, starting with you, just wanting to see, where do you see sort of the biggest gaps in terms of inequities in delivery of healthcare, and what are sort of the first steps we can take here?
Sure. So we at the health centers have been in this work for 55 years. And the thinking is that we want to get to 100% access and 0% disparities. And the 100% access begins with looking at things like, how do we get everyone insured? How do we give them the tools to be able to access the resources once they're insured or once there's a mechanism for payment? But that's, as Dr. Berwick outlined, just the beginning. There's the systemic issues that have to be addressed if you're going to make a meaningful difference. Here in Worcester, your Black and Brown members of the community have infection rates that are multiples of that of the white community. And that is in part because of the underlying metabolic conditions and other pre-existing health conditions that occur within our communities. It's also because of the conditions that they navigate every day. If you're asked to socially isolate, you've been exposed to coronavirus because you work in a laundry or you work on an assembly line, and you live in an apartment with shared housing that has one bathroom and 7 other people in that space, how do you reasonably do that? And if you are getting a test and you have to wait 4, 5, 6 days to get your results, again, how do you do that? And when you make a decision around, am I going to go to work or am I going to social isolate? When going to work is the only means of feeding your family, what kinds of decisions are you going to make? So it's important that we all have an awareness of it. I think there's a visceral reaction when we talk about systemic racism, because nobody wants to think of themselves as racist. And my belief is that we need to get people to not focus on the intention. Let's assume everyone's intentions are good. Let's just assume that. And let's focus on impact and recognize that, when somebody comes to you and says, you're a fish, and they come to you and say, gee, the water is warm. And you say, what's water? That's when it's an opportunity to recognize that this person's experience in the environment is very different from your person's experience. And we need to understand that, and then we need to address that. So first steps, in my estimation, maximize access through getting people insured, creating relationships and opportunities for people to navigate the system more effectively. And then it's having a real intention around the upstream issues and having an awareness without a sense of defensiveness around it, but with a sense of resolve. If we come together as a community, we can resolve this. One last thing, the pandemic has really laid bare this brutal reality, and also the fact that we're all in the same boat. And so even if you are reluctant to direct resources, outside of your immediate environment and outside of your particular interest, this has shown that your interest is squarely rooted in the communities like Maine South, where if we don't get the appropriate level of testing and treatment and access, the pandemic continues, and it continues to affect your life as well. It's a forest fire that does not remain contained. So I ask that we give that some thought as well.
All right, so addressing social inequities in health, next steps. I know maybe who wants to go next, Eric or maybe Carolyn?
We've spent a lot of time on this topic, and have a board meeting tomorrow, and they wanted me to boil it down to the 3 things that we've learned with kind of on our journey to work with our employee resource groups and do our community forums that we've done, and some that you have participated with, and to look at our data. And what I would say that, number one is something that Lou said. I always thought that treating everybody the same was doing a good job, and treating everybody the way I wanted to be treated. And the reality is that when you're working with patients or caregivers that have been prejudiced against their entire life, treating them the way a Caucasian male wants to be treated isn't enough. You have to understand the journey that they've been on and what life has been on like for them in order to really get to some of the inequities. And we're pushing hard right now to close the gap between Caucasian children getting their well child visit and Black and brown children and Latinx children getting their well child visit. And there's a gap of about 20% difference. And part of that is that, if you're worried about food security, housing security, job security, well, getting your kid to the well child visit might have to come fourth and fifth. Whereas if all those things are okay for you, sure, of course you're going to bring your kid in to be seen. So that you have to just take that equity pause, and with everything that you do and everything that you design in order to create a more equitable system. When we did our first Stop the Spread work testing site after the Black Lives Matter rally in Worcester, we did it on the Shrewsbury line with one of the richest zip codes you could find, because that was what was convenient for us. And, we weren't doing it intentionally because we were racist. We were just stupid in the sense that we didn't take a moment to say, where do the people that attended that rally, where do they live, and how hard is it going to be to get through a drive-through testing site? And so every other testing thereafter we did up until the winter hit and kind of shut us down with the mobile site was in the most underserved neighborhoods in Worcester. And what we found is a much higher infection rate than we found in the Shrewsbury line. And so we could have been sitting thinking things were wonderful and there was no spread of the infection because of just where we had our testing site. And instead, when we started to move and took that equity pause, we started to find more infections, and then we started to work with them in supported isolation, which was very, very hard for a lot of those folks. So I guess what I'll say is in everything that we do and design moving forward, we have to take an equity pause and we have to think, how is this going to impact Caucasian versus African American versus Latinx and other populations? And if we do that, we'll make better decisions and we'll start to close some of the gaps that exist. But if we don't, we're just going to continue to build things that really disadvantage people living in poverty and people of color.
We definitely care for a diverse patient population as well. We don't care for nearly as many children as Eric does over at UMass, but certainly a diverse adult population. And we have definitely learned, and again, COVID has shown a bright light on some of the inequities in a way that we hadn't seen before. And a lot of it is access to post-acute care and what sort of facilities we can get people into who can't go straight home, or perhaps are in a situation where, as Lou said, they are one of 8 or 10 people living in a small location and they need to self-quarantine. So there are a variety of things that we've worked on with our social services team, as well as with a variety of outside agencies to help wherever we possibly can with those inequities. And I think it's really opened our eyes to some of the things, even within our own walls, because we have employees of all different demographics and backgrounds and socioeconomic statuses. And we want to make sure that they have access to the same level of care. We want to make sure they have access to the same level of knowledge, the same level of trust in the system. So it is definitely a work in progress and something that we've been partnering with the city of Worcester as well. And we know we have work to do, and we look forward to being able to continually better serve all different types of patient populations throughout the full continuum of care.
And Brad, I would just add, I think that Eric, Lou, and Carolyn touched on all the major issues, but the one piece I'd like to add is workforce development and making sure that our workforce really mirrors the populations we serve. Our members probably cover about 60 different languages, and we do make a concerted effort, particularly among our navigators, to hire bilingual navigators. But I think we need to do more. And we're sitting in the middle of Worcester, which has all sorts of wonderful colleges and universities. I'd like to see all of us do more to build pipelines, starting with high school through college level educational institutions, to really start creating that pipeline so that we can start attracting more talent and more diversity to our workforce.
One of the thoughts I have beyond what we've been talking about, Brad, is who's responsible? Where does the buck stop with respect to some of these social issues and determinants we're talking about? If I say, who's responsible for making sure that surgery at UMass Memorial is safe? I have no question. The answer is Eric Dixon and the Board of Trustees. The buck stops there. If I say who is responsible for seeing that every kid cared for at Fallon is vaccinated, it's Carolyn and Rich. I mean, you can pin the rose, as they say in the military, on somebody. But if I say who will make it the case that from some point onward there's never a hungry child in Worcester, or that the pathway to incarceration is changed in Worcester, or that everyone has a roof over their head or isn't afraid, who's got the ball? And until we have that sense of ownership somewhere, I don't think these social determinants will be easily tackled at all.
All right, so moving on to our next area of discussion. We could probably talk on any single one of these topics for a full 60 minutes, but to keep going through the long list that we have, mental and behavioral health issues have certainly got more exposure in the last few years, but the coronavirus pandemic has unleashed a new wave of mental health issues. In fact, I think I saw a study yesterday saying America's mental health was an all-time low, which I don't know about that, but certainly isn't doing well. So in terms of what the next steps are, how do we improve mental health and then delivery of mental health? And Carolyn Langer, if you want to maybe jump on that one first.
Sure. Yeah, this is a topic that is just so important to me, important to Fallon. In fact, we had our Service and Quality Oversight Committee last night. That's a subcommittee of the board, and this was the main topic of discussion. So we just have a paucity of behavioral health specialists, and the vast majority of behavioral health care, as well as psych meds, are delivered in a primary care practice. So we need to be a little bit more creative. There's no way in the short term that we're going to be able to build out a sufficiently sized behavioral health workforce. And so we need to think about some creative alternatives. For example, we talked about telehealth before, but specifically with respect to telebehavioral health, this is another area where we saw significant uptake. And this is an indication that is particularly amenable to telehealth. But we also need to be doing more things, looking at digital apps, looking at self-help tools. Dr. Berwick mentioned self-management, more innovative models such as group therapy. In addition to that, I'm a big proponent of behavioral health integration, particularly behavioral health integration in primary care settings. And there's some really outstanding models right here in Worcester. RMG is really doing a fantastic job integrating behavioral health partners into their primary care practices. And then finally, to really support that type of model and some of these creative innovations, again, we need to think about payment models that move away from fee-for-service and that really help practices and health systems to address populations so that they have the incentive to invest in that infrastructure. And then the last area I'll touch on is substance use disorder treatment. I am very concerned that during the pandemic, we saw a number of areas where patients were reluctant to seek out care, and certainly behavioral health in general and substance use disorder specifically were areas where we saw some decrease in utilization. So we need to, again, be creative. At Fallon, we are exploring new models for supporting medication-assisted therapy, including incorporating a component of telehealth to make that type of treatment more accessible, including in some of our rural areas as well.
Just would add that, fee-for-service systems get bashed a lot in the United States. The highest performing healthcare systems in the world are typically on fee-for-service, and they're not in ACOs as we have described. The problem with the American fee-for-service system is that you pay so much more for procedural-based services and imaging and anything that has to do now with a scalpel or a vascular catheter, which is versus the cognitive specialties, which requires a lot of coordination of care, primary care, the coordination of care that the navigators do with NaviCare. Our docs love that. And so, if you can't get to a system like Don described, where you have a regional set of dollars that we're going to all work together to manage the care of a population, right? A Medicare Advantage type system that covers all of a region, then you've got to tweak the fee-for-service system, and you've got to pay more for coordination, more for the cognitive specialties, and less for those that are procedurally based.
So the only thing I would add to that, Eric, is that we do hear from our providers who are in capitated arrangements or receiving global payments that they appreciate, to your earlier point, Eric, not having the administrative hassle of having to bill for each and every service. And there is a lot of care, you don't need me to tell you, that is delivered today that is not reimbursable. So when the pediatrician coordinates with the school nurse or with social services, when letters are written for different purposes such as disability, these are services that are being provided that are not for which the providers are not being reimbursed. And so it really frees up the practices to deploy their resources where they feel that they can most benefit their patients and be able to address some of these issues like the social determinants without having to worry whether or not they're going to be reimbursed for each and every service.
I think a Kaiser-like system for Central Massachusetts would be the ideal model. And instead of Carolyn and I trying to compete, she buys a robot, I got to buy a bigger robot, and then she has to buy a different one. And we put up these billboards about who's the tops in robotic surgery, which adds tiny amount of, if any, of value relative to the other things that we can be doing. So yeah, I think the ideal state would be something like Don described, a regional system of care, an integrated delivery system that could take all that administrative burden out. The Kaiser docs aren't worried about what they're getting paid for a virtual visit versus an in-person versus doing some of the things that they need to do to coordinate care. But, that's the dream.
My understanding is that in the pandemic, primary care practices, physician practices that are being paid on a different model with payment have done better financially. They've been much more survivable. That's true. That's definitely the national pattern. Fee-for-service has been not a good way to get paid during the COVID pandemic.
I love the idea of a regional system, even more so the idea of an ecosystem, and letting us stratify and imagine the resources differently and meeting people where they're at. In thinking about innovation in Zimbabwe, they have what's called the Grandma Bench, where they recognized the unique position in society of the elder women in the communities, and they taught them a little bit of CBT and had them sit outside the clinics, and people could come up and engage and get a little bit of time with their grandmother. We have, I think, opportunities to think about that across our ecosystem, looking at places where people have some stigma around behavioral health, and maybe the intervention is a mindfulness-based stress reduction. Recognizing that loneliness is a true killer, and how can we create opportunities for engaging and having people feel less lonely. And I believe I heard in Minnesota, or one of those very cold states, they would have a phone conference across a group of elderly patients where they would sing the old standards. And it was just an opportunity to connect, even if you were snowed in, and know that somebody was out there thinking about you and connecting with you. I think if we recognize that behavioral health is as critical as medical, we can reimagine our system, create an ecosystem, and address these needs.
And also from a behavioral health standpoint, as was mentioned before, the telemedicine ad has been really helpful in getting people to actually attend their appointments, both in group sessions and individual. So that's been positive. Regarding the comments that have been made about Central Massachusetts ecosystem, I think it's consistent with conversations we've had, and we know that as you travel further east in Massachusetts, the cost of care goes up fairly significantly. And so from our standpoint, by being able to care for the residents of Central Massachusetts in Central Massachusetts, everybody wins because it creates more jobs, it keeps people local, it reduces the cost of care, and you can get great quality care at both our hospitals in Worcester. So I think that's definitely something for us to strive towards, and something that we have been discussing.
And then, so it is 9:54. We have told everyone we would stop at 10. I know the conversation is going really strongly, and I would like to continue. So I think if all the panelists are fine, we'll jump into our next one and maybe push that 10 o'clock a little bit. If any of you have a hard stop at 10, though, completely understand, and if you want to jump right off. But just jumping into the next topic, which has to do with, touched on a little bit already, but staffing in the healthcare industry. Particularly finding skilled doctors and nurses, as well as the rest of the healthcare community. You do hear new anecdotes about new levels of employee burnout, compounded by the issues of the pandemic. So what are your staffing concerns right now, and how can those issues be solved either immediately or over the long term? And Lou, let's go with you first.
Yeah, several concerns. Our team has really stepped up to this. And, in healthcare, we employ the type of people who run towards the disaster, not run away from the disaster. But they are human. And this higher level of demand over an extended period of time has created a level of burnout for several of our people. And so it's understanding and recognizing how we can support people in this challenging period of time. And sometimes it's the only tool that I have is to be able to say, it's hard. I know that it's hard, and we'll get through this. And that's important to do. So that's I think a first level. We have struggled with people needing to engage on all the issues that have been brought up with this pandemic, the lack of childcare because of the closures of school, and needing to be at home versus being here at the line of the work. Dealing with people who have had COVID exposure and who need to go offline. And when they're the people who are the treaters, you've now got to figure out, well, how are you going to fill in that part of your line of defense? But early on in this whole pandemic, the questions were more existential. The questions were, how am I going to be able to keep my workforce and pay them when the way that we fund our organization is through visits, and we've told everybody to stay home? And that was a real challenge for us. We made a decision that we would figure out a way. We were fortunate in that we were able to access the PPP, Paycheck Protection Program, and that allowed us to redeploy individuals within our organization in jobs that needed to be done, not necessarily the jobs that they had on their job description. And that was sort of an important part of helping our workforce get through this. So the workforce concerns are the same concerns across society. It just sort of all comes together in this dynamic melange of issues that we just try to navigate as best we can each day.
If anyone else wants to jump on the staffing question before we wrap things up here?
Well, I think that we all recognize just how hard it is to fill the roles that we have. And really what it says is you've got to find a way to keep those people there. And you keep those people there by having them feel valued. Nobody wants to be in a job where they don't feel valued. Some people will stick around for the pay if the benefits are good or whatever. And I think that the best way to make your people feel valued is that they are contributing and that their ideas matter. And, you know, for the 7 years leading up to the COVID crisis, we had been training every one of our employees in process improvement on the way in the door, and had an idea system in place for our employees that we've instituted over 100,000 of their ideas about how we can improve. And, you know, and we had made some progress because of it. But when COVID hit, it was that training, that 7 years of investment in our people and development that paid the greatest dividends. Because you had to send the people out and say, you know, build a field hospital in a convention center in 8 days, build testing capacity for the community from an empty warehouse, or do mobile testing capacity. There was just these millions of problems we had to solve, and no one person could solve them all. You had to depend on your people to solve them. And when we came out of the first surge, what the entire team, leadership team, said was, we've got to double down on investing in our people to create the greatest problem solving workforce in the nation. And that's, we want an army of problem solvers. And it's not just good for us in terms of solving more problems faster. It makes the people feel valued when you can give them an objective and not give them an exactly how to do something, and they can create a testing center from nothing. And so, you know, the big lesson for us is if you can invest in your people, but not when the crisis hits, before the crisis hits, get them into becoming the greatest problem solvers possible, help them feel valued, and make them really be valued, not just feel valued, but be valued. And you'll create a loyal workforce that will stick with you. And that's can be a differentiator for you in any business.
And Brad, what I would just like to add to that, in addition to being a health plan, Fallon is a provider, particularly through our PACE program. And one of the benefits of that model is the interdisciplinary team. And there have been a number of studies showing that clinicians who participate in interdisciplinary models of care do have higher levels of provider satisfaction. I know it sounds cliche, but it really does enable them to practice to the top of their license, to do what they were trained to do, and to really develop a more coordinated, holistic approach to taking care of patients. So our PACE program actually set up an infirmary, something like Eric's DCU center, but obviously on a much, much smaller scale, to support our COVID-19 participants in our PACE program. And we had no lack of volunteers from our PACE staff to staff that infirmary. They were excited. And I think part of that is because of the benefits of having this interdisciplinary team.
And one of the things that was helpful in doing this rapid problem solving, as has been mentioned, especially during the first surge, is most of our daily jobs, and when I say our, I mean people in leadership positions, sort of went out the window, and your 100% focus was on COVID and the response. So it was very, very easy to be out and about, talking to the folks actually caring for the patients on a daily basis, listening to them, and they were the ones who knew how to solve the problems. And it was very easy for them to provide that feedback. And so when we did have a decrease in cases over the summer, it was great to see some of those ideas keep going. And as Eric mentioned, having those employees feel valued and feeling heard and say, wow, my feedback caused us to change this, that helped make care better, that helped make this easier, that helped get rid of a workaround and hardwire something, has been great. And so we have been learning from the first surge as we go into the second surge, and also making sure that we're learning those performance improvement ways to tackle problems going forward, so it can continue to help us get better. And certainly keeping it fun whenever you possibly can, whether it's celebrating COVID discharges, whether it's in the holidays, perhaps an ugly sweater competition. We want to make sure that we're doing things that not only make them feel valued, but make work a fun place to be.
Carolyn, can we see your ugly sweater?
Certainly, it has a llama on it. That's all I'll say for now.
Well, I think on that comment, maybe we should head towards wrapping things up. So a lot of big topics talked about today, but maybe just another 1 or 2, maybe 3 minutes here. Give each of you about 30 seconds to free range anything you want on various topics we've touched on.
Brad?
Yep.
I see that there are a couple of questions in the chat. Did we want to address that?
I think, well, Dr. Berwick did a good job of answering the ones on vaccination, but just really quickly bring up who owns the ball regarding to hunger and homelessness in Worcester. The topic quickly changed, but if starting today, what would be an organization that maybe people could look to support on that, or a concept to get behind? I don't know if anyone has any.
Well, there are a number of homeless service providers in the city, and I think the place for the coordination of that work is really rests with Dr. Maddie Castile, our Commissioner of Health and Human Services for the city, and her quality of life team. She brings together folks around the table to have the conversations. I think it's been, I think it is important that we recognize the unique effort that happened around the homeless, especially in this time of COVID. It was a population that was frankly a little difficult to test, trace, and treat. But community leaders, including Dr. Michael Hirsch, came together and said, how do we do this? And how do we create a group effort around this collaboration? And so we were able to, in the first wave, help stand up a part of the DCU Center for essentially treatment and isolation and containment. And we were able to test rapidly and get people, what they needed. I'm imagining that going into the second wave, there'll be a similar effort. I know that our team has been part of those conversations. So I would direct the question to Maddie and the city and the quality of life team.
This is certainly an important topic to get behind. So does anyone want to start off with any parting thoughts maybe here? Just trying to keep it concise. I know that big concepts don't necessarily drill down into 20-second sound bites, but maybe Carolyn Langer, if you want to start things off.
Sure. So we touched on a number of topics today, but I think I would summarize by saying that we need to continue to leverage the lessons learned during the pandemic. As Dr. Berwick said at the outset, let's keep the momentum going. Let's engage in that fast learning and pivoting, and make sure that the interventions that we've put in place are sustained. So we talked about continuing to make healthcare accessible, particularly in light of social determinants and improving health disparities. really making healthcare proximate, as I mentioned in the beginning, providing care where the members are, pushing that care further into the community and even into the homes. And then finally, really thinking about how we continue to evolve payment models and models of care. I think, the horse has already left the barn in terms of fee for service. We're just not going back. And so we need to think about whether we're talking about consolidated payment or some other form of payment. Regardless, we need to think about how we can best structure these payment models to incent providers to put that infrastructure in place to really address populations. And then finally, I'll just close on calling out specifically behavioral health, since it is such a critical area, and continuing to need to innovate, particularly in light of a shortage of workforce and behavioral health specialists, to think about how we can continue to make behavioral health more accessible for those who need those services. Thank you.
And Carolyn Jackson, maybe any last thoughts before we wrap things up?
I just want to remind people what we've talked about, bring it back to the COVID basics of making sure you be socially distant, wash your hands, wear a mask, practice everything we've been asking you to practice. It will be enormously beneficial for those on the front lines over the coming weeks. And also don't delay if you have preventive care, or if you need to go to the emergency department. You don't need to be concerned about coming to the hospitals. They are safe places. We have what we need. So those are the two things I want to leave you with this morning.
All right, Eric.
Well, I'm going to steal one of Lou's lines. You get things done with technology and teamwork. And if I had to pick one or the other, it would be teamwork. And what I've seen in Worcester and the surrounding area is we all came together when our communities needed us most to work together during COVID. Let's keep that momentum going. Let's continue that teamwork and start to get into some of the things that Dawn was talking about, these social determinants of health. We employ a lot of people. We purchase a lot of services. We have an investment portfolio. Let's put some of that power into transforming some of these neighborhoods in central Massachusetts that really need an investment. And it'll pay great, great dividends for us. We are in a position to do something really special, I think, in Worcester County and central Massachusetts. And let's just keep the momentum going and take great care of our patients and one another.
All right, Lou, maybe if you want to give us our second to last parting thought here.
Happy to. I think I've heard it said, nothing changes if nothing changes. As painful as 2020 has been and the COVID-19 pandemic, it really did spur a lot of conversation and a lot of thinking, and helped us to reset what we thought was possible. I'm asking that we in the community have a long memory around some of this, and that we maintain this set of conversations around access and equity, and inequity and racial and social justice, that we recognize that we're all tied together, and that we are making an investment. The question is, are we getting the return that we're satisfied with, or do we need to change or shift how we make those investments? And there are lots of folks around the table here who are on the front line of that thinking, and I appreciate all of them and looking forward to doing more with them going forward.
And lastly, Dr. Berg.
Well, really, ever since I ran for the Democratic nomination for governor in the early part of this decade, and I got to see a lot of the state. But I must say, I always felt something special about Worcester and the Central Mass area. The reason is that the solutions to everything we're talking about is what Lou just referred to. It's community. It's a sense that you're in this together, and it's really hard to build that in some of the other areas of the state or the nation. But you've got something out there in the water about being together on behalf of your community. And if you're able to stay together and get some goals on the screen, I mean, you have to intend to accomplish something and get that done. You can set a real example, not just for the state, but for communities around the nation. So I wish you well, and I'm certainly rooting for you.
All right, well, thank you again, our keynote, Dr. Berwick, and our panelists, Lou, Eric, Carolyn, and Carolyn. Thank you so much for this incredibly insightful conversation. I have a lot to digest going forward now. Special thanks to our sponsor of this annual event, Fallon Health. And just a quick reminder that WBJ will be hosting a telehealth webcast on December 17th at 9 a.m. We'll include a link to registration for that session, along with links with info from today's session in our post-event follow-up email. And everyone enjoy the rest of your day.